So hello everyone, welcome to Insta Solution. Question number 1. So today we have an assertion reasoning type question where the assertion says infranasal coloboma of the iris is most common, and the reasoning is the hyaloid fissure persists inferonasally in the neural crest most commonly. So friends, to answer this question, you must know the basics of embryology and development of the eyeball. So let's go back to that time and discuss something about embryology. Now, you know that we have a neuroectodermal cup from which your iris, your retina, vitreous and your optic nerve develops, okay? Now, during the time of gestation, this eyeball needs nourishment, and this nourishment will be through the hyaloid artery, which passes through a gap in this neuroectodermal cup, okay? So we have a gap here, and this gap is called as your optic fissure, okay? So this is your gap, which is your optic fissure. It is also called as the hyaloid fissure. Now, this gap generally closes at around 6th to 7th week of gestation, okay? This normally closes. But if this doesn't close, it leads to a congenital anomaly, a iris coloboma. So if you can see this picture is very important for your exam. This picture shows that there is a defect in the iris. The pupil is abnormal. So this pupil is abnormal, and this particular anomaly is called as iris coloboma. So what is iris coloboma? It is a persistence of your optic fissure or your hyaloid fissure. The fissure doesn't close, okay? Now this coloboma can be divided into a typical coloboma or a atypical coloboma, depending upon the position of the coloboma. So whenever your coloboma is infranasal, the same is given in this picture. Whenever your coloboma is infranasal in location, you call it typical. If the coloboma is elsewhere, anywhere, you call it atypical. So if this is like that, it will be a atypical coloboma. A typical coloboma is always infranasal, okay? Now, sometimes you may see a keyhole defect in the iris. So this is another question, a keyhole defect. Can you see that? So this typically is your keyhole defect in the iris. This is also your infranasal iris coloboma, which is showing you a keyhole defect. Now friends, many a times this coloboma is also associated with the coloboma of the retina and choroid. So we call it a choroidal coloboma, another potential expected question. So can you see in this picture, this white area behind your optic disc, below your optic disc, this white area is nothing but the visible sclera through the indirect ophthalmoscope. So this is a coloboma where your retina and choroid are not completely developed. So all the structures in your neuroectodermal region will be deficient. That is why you have a retinochoroidal or a chorioretinal coloboma. Okay, so this is your choroidal coloboma. Now, let's go back to the question and try to solve this. Infranasal coloboma of the iris is most common. So this is a correct line, isn't it? It is the most common one. That is why we call it a typical coloboma. Now, the hyaloid fissure persists infranasally. This is true. But this is not in neural crest. This actually is present in the neuroectoderm. Alright, so this reasoning is not correct. That is why we have option number C as the correct option. So A, assertion is a correct statement, but the reasoning is wrong. The statement itself is wrong. Okay. So welcome to Insta Solution question number 2. Today we have a multiple answer type question. And the question is, what is not true about endophthalmitis? So endophthalmitis is a very important question in your exam, and today we will be discussing something on endophthalmitis and some new potential questions on this particular topic. So as you all know that by the term endophthalmitis, it means that there is a very severe inflammation of the inner coats of the eyeball with vitreous exudation. Now, you can have endogenous cases of endophthalmitis where you have either an immunocompromised state or you have any systemic infection in the body which can go to your eye and cause endophthalmitis. The cases are very less. Now, the most cases are coming from some exogenous source. It can be after post-trauma or can be after a surgery in the eye. Now, cases of trauma. This is mainly after Bacillus cereus. Okay, so you should know what is the organism for all such cases. Bacillus cereus will be mainly after trauma. Now, early endophthalmitis, we all know that this is after coagulase negative staph, which is also called as staph epidermidis. And late cases may be after either a fungus infection or Propionibacterium acne. Okay. Now, these questions have already been asked. Now, you should know something very special about Propionibacterium acne and late endophthalmitis. Now, when you have endophthalmitis in the late postoperative period, by especially Propionibacterium acne, you may develop a plaque on the lens itself. So this plaque will be your sign which will tell you that this is a case of endophthalmitis. And while we do vitrectomy in such patients, we may have to explant the IOL also. Now, when endophthalmitis patient comes to us with early presentation, that is usually 2 to 3 days after a surgery, they come to us with pain, redness and sudden drop in vision. So these three are the danger symptoms. Now, when we see these patients, we find classically the cornea is hazy. You have a hazy cornea and you have the pathognomic hypopyon. So hypopyon is nothing but pus in anterior chamber, which itself is a individual picture question. Now, the treatment is on the line of endophthalmitis vitrectomy study. So EVS study says that if your vision is poor, less than PR accurate, less than finger counting close to face, you may have to do a urgent vitrectomy. Okay. Now, they also say that if the vision is slightly better, that means if the vision is PR accurate or finger counting close to face, you may need not to do a vitrectomy. You can treat first the patient by doing a tap of the vitreous and giving intravitreal antibiotics. They also said that there is no role or hardly any role of systemic antibiotics. They say that we have to give only intravitreal antibiotics which are worth. Otherwise, there is no role of systemic antibiotics. So, this much at least you should know about endophthalmitis. Now, let's try to solve the question. Late endophthalmitis cases may show IOL plaque that I told you can be found. Streptococcus is the most common cause in post-traumatic cases. No, guys, it's not. It is your Bacillus cereus. So systemic antibiotics have a limited role in post-operative cases. Yes, that's again a correct statement. They have barely any role. Now, urgent vitrectomy is the first line of treatment. No, the first line of treatment is intravitreal antibiotics and not vitrectomy. So hello everyone, welcome to Insta Solution number 3. So today we have an image-based question with us. The picture given below suggests what? So this is your characteristic golden ring sign. Okay, so can you all appreciate this ring here? This ring is your golden ring, which is seen when we do phacoemulsification, and this characteristically tells you that you have done a complete hydrodelineation. Okay, so important expected question. Now let's quickly discuss what are the different steps in phacoemulsification and where do we do hydrodelineation and when we get a golden ring. Okay, so when we start with phacoemulsification, we make a self-sealed incision, okay, which is like 3.2 millimeter, a standard incision. Now after we make an incision, we create an opening in the form of CCC, continuous curvilinear capsulorhexis. So this is your CCC in process. Now afterwards, you fill your anterior chamber with your viscoelastics and you start, you have to do some hydro procedures. Now hydro procedures are of two types. You have to do hydro dissection and you have to do hydrodelineation. Now dissection means that you have to separate the capsule from the cortex and nucleus. Okay, so what we do, we inject the fluid from the main port, and when we inject the fluid with force, there is a separation of capsule from the cortex. So this process is called as dissection. Now when we are expecting that we have a soft cataract, either a grade 1 or grade 2 cataract, we want to have a cushion of cortex behind. Okay, so then we also do a hydrodelineation. Now the meaning of this step is that we inject fluid wave within the substance of the lens, and here we are separating the nucleus from the cortex. So we get a cushion behind our nucleus. Now we can safely do manipulation of the nucleus. Okay, so we are separating the endonucleus from the exonucleus, you can also see. Now when you are doing hydrodelineation, sometimes we see a golden ring sign, and this is a confirmatory sign that your nucleus is completely separated from the rest of the cortex. Okay, so this is called as your golden ring sign. Now let's see what we do next. Now we take the phacoprobe, and this ultrasonic power is used to break the nucleus into multiple small pieces. This is called as sculpting. Now when we get smaller pieces of nucleus, one by one all the pieces of nucleus will be emulsified. Finally, you do a cortical cleanup, you fill the bag, okay, and then you inject the IOL. So these are the steps of phacoemulsification, and again I'm repeating, golden ring sign is for hydrodelineation. So welcome to Insta solution number 4. So signs of chronic iridocyclitis includes all except muddy iris, neovascularization of iris, pigmented KPs or atrophic iris. So friends, the answer here is a muddy iris. Now friends, when we have an acute case of iridocyclitis, acute inflammation, you see a variety of signs. You have cells, flare, keratic precipitates, nodules, pupil becomes small, your iris becomes boggy, you may have a hypopyon, isn't it? Now when we have a acute case, your iris becomes swollen, your iris is inflamed, so it becomes swollen, it becomes boggy. Okay, now this is the normal architecture of the iris. When you have these small things, these small empty areas are called as crypts. Okay, so this is your normal architecture. Now when iris becomes boggy in an acute attack, it becomes swollen, there is loss of crypts. So loss of crypts are seen in this picture. As you can see here, a lot of difference is there. So this is called as a muddy iris appearance. Okay, the architecture is lost and your iris becomes boggy. So muddy iris is actually a feature of an acute case. Now let's understand what is the meaning of the term chronic iridocyclitis. So a recurrent inflammation which is coming within less than 3 months after you stop the treatment is termed as a chronic iridocyclitis. First of all, this definition is important. Okay. Now, when we have a case of chronic iridocyclitis, you don't have cells. Flare may be persisting. You may have pigmented KPs. Okay, the left out old KPs may turn pigmented. Now, again, you may have a loss of crypts. But this is not a muddy iris appearance. The loss of crypts will be because of the atrophy of iris. So, in persistent cases, your iris becomes atrophic. Okay. It may show some holes also. Now, neovascularization of iris is obviously, it can be seen only in chronic cases, because when you have a chronic ischemia, your VEGF comes up and then you will have new vessels in the iris, which is called as neovascularization of iris. So, muddy iris is actually a feature of acute iridocyclitis. So, hello everyone, welcome to Insta Solution question number 5. So, false about Adie's pupil. So, friends, all the abnormal pupils are very important for your exam. You have to study everything about the pupils, okay, normal as well as the many abnormal pupils. Today, we will be discussing a question on Adie's pupil. So, Adie's tonic pupil, let us discuss this. This is actually a unilateral, slightly dilated pupil. Now, as the name suggests, Adie's, the full name is Adie's tonic pupil. This tonic pupil is a little stubborn pupil. Stubborn means it is slow to react. So it is slow to constrict, slow, rigid to get dilated. Okay. So this is a stubborn kind of pupil. Now what happens here? What is the basic problem? The basic problem lies in your ciliary ganglion and the postganglionic parasympathetic fibers which are going from the ciliary ganglion to your sphincter pupil. Okay. So the problem here is in the ciliary ganglion or your postganglionic fibers. Now friends, these, because your parasympathetic pathway is involved, sometimes you may have an association of absent deep tendon reflexes. Okay, this is commonly seen in young or middle-aged females, where you have a Adie's tonic pupil, and with that they have absent deep tendon jerk reflex. Okay, so now what is the other thing you have? There is an involvement of a sectoral part of the iris. So there is a sectoral iris atrophy, sectoral iris involvement. Now what happens? When you show the light, the pupil will hardly react. Okay, so here also your light reflex is lost, but your accommodation reflex is present. Here also you may have a light near dissociation. But don't get confused between this pupil or Argyll-Robertson pupil. Why? Because Argyll-Robertson pupil is a bilateral small pupil. Adie's tonic pupil is a unilateral dilated pupil. Okay. Though the accommodation reflex is present, but this reflex is also very sluggish. Very sluggish. Now, because of this sectoral iris involvement, whenever your iris is contracting, it shows some vermiform kind of contraction. So another question, that vermiform movement of iris is seen in which pupil? It is seen in Adie's pupil. Okay. Now, what next? How do you diagnose? So you diagnose this by putting some drop of pilocarpine. Now friends, when we put pilocarpine, a normal solution, which is 2%, our pupil will constrict. Okay, so my pupil will constrict when I put 2% pilocarpine. But these patients become very hypersensitive. There is a denervation hypersensitivity. So when you put a very weak solution of pilocarpine, then also these pupil constrict. Okay, so even on the weak solution on pilocarpine, these patients will show a constriction of the pupil. This is because of the denervation hypersensitivity. So this is something about Adie's tonic pupil, a very important question. Let's see if we can mark the answer. So it is slow to react. Yes, this is slow to react. There can be absent deep tendon reflexes. Yes, this is a true statement. They become hypersensitive to pilocarpine. Yes. But this pupil is not a bilateral small pupil. This pupil is a unilateral dilated pupil. Hence, this is the answer. Hello friends, welcome to Insta Solution question number 6. Today we have the match the following type of question. So on the left we have some clinical retinal findings, and on the right we have the name of the layers where you can see those findings. So first is cotton wool spot, hard exudate, drusen and Dallen-Fuchs nodule. So friends, we will be discussing them with the help of pictures also. As you know that cotton wool spots and hard exudates, both of them can be seen in various disorders. Now cotton wool spots are usually large, plain, fluffy lesions which are there in your retina. Okay. Now cotton wool spots classically are present in your nerve fiber layer. Basically, these are the areas of axonal stasis in your nerve fiber layer. Okay, so you see them as cotton wool spots. Cotton wool spots are also called as soft exudate, but this term is a misnomer because there is no exudation. Okay, so this is your cotton wool spot. Now, hard exudates. Hard exudates are smaller. They are well defined yellow lesions which are near your capillaries. They are near the capillaries because they are actually the exudation from the capillaries itself. So these are called as hard exudates. Now they are seen mainly in your outer plexiform layer and inner nuclear layer complex. Classically in the outer plexiform layer. Now you may also say that this is present when they are present in the macula. You call this layer as Henle's layer, isn't it? So OPL in macula has a different arrangement of cells. That's why we have named this layer as Henle's layer. Now let's talk about drusen. So friends, drusen are nothing but eosinophilic, pass positive, extracellular waste material which is collected in your Bruch's membrane. So Bruch's membrane is just beneath your RP. Okay, between your choroid and RP you have your Bruch's membrane. So that is the area where you have collection of drusen, classically seen in patients of ARMD, the dry form. Now, this is your picture here for drusen. You see some yellow lesions spread throughout your macula. Now, friends, sometimes you may get confused between drusen and hard exudate. So, this is very important how to tell whether this is a drusen or a hard exudate. So, guys, I just told you that drusen are beneath the retina, subretinal. So, you always find that these yellow lesions are over these vessels. So you will be able to see these vessels. Why? Because these lesions are present beneath the retina, beneath these vessels. These vessels are there in the retina. So lesions will be beneath the vessels. So you will see clear view of vessels over these lesions. But when we see hard exudates, you will not see the vessels. Why? Because hard exudates and vessels, both of them are in retina. So the view of vessel will be obscured. So that is how you can identify whether this lesion is drusen or a hard exudate of cystoid macular edema. So drusens are subretinal. This is what you have to check. Subretinal. Now let's see what are Dallen-Fuchs moduli. So friends, can you appreciate these small lesions here? It appears that they are in your vitreous like snowballs, but they are not. They are actually present in your choroid or your RPE as collection of epithelioid cells, classically in patients of BKH and sympathetic ophthalmia. So you have two conditions where you see Dallen-Fuchs nodules. Okay, so let's go back and try to solve the question here. So cotton wool spot, as I told you, this is seen in nerve fiber layer. Hard exudates you have in Henle's layer or your OPL, inner nuclear layer complex. Drusen are there in your Bruch's membrane and Dallen-Fuchs nodules are in choroid. So B is your answer. This is your best answer here. So hello everyone, welcome to Insta Solution question number 7. Today we have a clinical scenario based question here. So let us discuss the question. So a young patient presents with a painless red eye with a very high intraocular pressure of 60 millimeters of mercury. Now, when you see on slit lamp, only few cells are present. So, what is this condition? The answer typically is glaucomatocyclitic crisis. Now, friends, if you know this question, if you know what is glaucomatocyclitic crisis, you can easily answer this. So, let us discuss what is glaucomatocyclitic crisis or a Posner-Schlossman syndrome. So, this is another one, another name, another term for glaucomatocyclitic crisis. Now, it was found that in young individuals, there was a very high intraocular pressure. Idiopathic cases were most common, but there was an association sometimes of cytomegalovirus with certain cases. Now, when we see in slit lamp, patients usually have a very less kind of anterior chamber reaction, which is not corroborating with a high intraocular pressure. So these patients were known to have a separate entity of anterior uveitis. Okay, so this is a different kind of anterior uveitis where the amount of inflammation does not match with the high amount of intraocular pressure. So the basic problem here was of trabeculitis. Now the meaning of the word trabeculitis is this inflammation of the trabecular meshwork itself. Okay, so here you don't have inflammation of the uveal tract. Mainly the inflammation is in the trabecular meshwork. Okay, so it's different kind of uveitis. Now let's see if we can rule out the other options as well in this question. So acute anterior uveitis will be absolutely out because you have other features in your anterior chamber and pressure. Hardly there is a pressure in one single attack of 60 millimeters of mercury. Now, acute papilledema has no relation with your high IOP, so this is again absolutely out. Now, open angle glaucoma, we cannot consider this option even because this is a young patient, okay? So, young patient usually don't have open angle glaucoma. This occurs usually after the age of 60 years. So, again, when we rule out the other options, the answer comes out to be glaucomatocyclitic crisis. So hello students, welcome to Insta Solution question number 8. So not an absolute contraindication of corneal transplantation. You have here multiple answer type question. So age more than 65. So is age a criteria? Not at all. So friends, a very important question, age is not a contraindication. You can take a cornea of a very old individual, you can even take a cornea of a neonate, provided the cornea is clear and healthy. Okay, so if the cornea is healthy, the cornea has a good endothelial cell count, you can definitely take that. But definitely, a neonate's cornea will not be preferred by us because of the size. Okay, you know that the cornea attains its normal size by the age of 2 years. So, a small baby's cornea will not be preferred because of the chances of astigmatism and organ failure. Otherwise, age is not an absolute contraindication. Now, let us first discuss what are the contraindications of a corneal transplantation, because I want to tell you some really important points. Now, first of all is a common one, death due to unknown cause. You can't take a cornea where the cause of death is not known. Not any kind of systemic infection in the body prevailing at the time of death, you can't take the cornea. Similarly, any active ocular infection or any ocular malignancy, you can't take the cornea. Okay. Now, some prion diseases, okay, rabies is another one, or there is a recipient of a transplanted organ, you can't take the cornea. Now, some different kind of contraindications, guys, are also existing, which I really want to tell you. This is about your EDAA standards. So, non-medical IV drug use in last 5 years, or male-to-male sexual contact in last 5 years, or imprisonment for 72 hours in the last 12 months. So guys, such kind of contraindications are also existing. That is why you should know all the type of contraindications for corneal transplantation. Now let's solve this question. So age, I told you, is not an absolute contraindication. Rabies is, SSPE is, death due to unknown cause is the first of them. But a history of a viral keratitis is not an absolute contraindication, because I told you that any active inflammation, any active problem in the eye is a contraindication, but a history of a prior ocular disease is not a contraindication. So here we have age and a prior history of viral keratitis as the correct answers. So hello dear students, welcome to Insta Solution question number 9. So today we have a mathematical type of question here. A patient with IOP of 19 millimeters of mercury who underwent LASIK for a -5 diopter of myopia. So what would be her measured IOP after LASIK? So after LASIK, when he comes to me and I want to check his intraocular pressure by a Goldman applanation tonometer, will the IOP be 19 or will the measured IOP be high or low? So first of all, friends, you should know some basic calculations here in LASIK and how we measure the IOP. So let us see some numerals here. So thickness for the epithelial flap when we are considering a patient should be minimum of 150 to 160 micron. Okay, so this is individually a question. Now when we do LASIK, we do a stromal ablation. So after stromal ablation, the minimal thickness of the stroma left should be minimally 250 to 300 microns. Okay, different surgeons have different opinions, but it is mainly 250 to 300 microns which should be left after LASIK. Now, when you do a stromal ablation, it is like you have to ablate approximately 12 to 15 microns for correction of -1 diopter of myopia. So if you want to correct -5 diopters, how much should be ablated? How much should be thinned out? Approximately 75 microns, isn't it? Simple mathematics, like for 1 microns, 15, so for 1 diopter, 15 microns, 5 diopters, approximately 75 microns. Now, this is very important. What is the correction factor? So, we have many types of correction factor, but what we commonly use is the Ehler's correction. So, Ehler found that for every 10 microns decrease in thickness of the central cornea, you should subtract 0.7 millimeters of mercury from the calculated IOP on Goldman applanation tonometer. Now, because Goldman applanation tonometer has been standardized for approximately 520 microns of the central corneal thickness. You have this standardization earlier. Okay, so this has been standardized for 520 microns as the central corneal thickness. Now, when your central corneal thickness goes down, what will happen? You will have a change of the measured IOP. Now, let us see how we come to know the answer. So, for 10 microns, we have a change of 0.7. So, what will be the change for 75 microns? It would be approximately 4.9 millimeters of mercury, isn't it? So, what will be the answer here? You have to subtract approximately 4.9 or 5 from 19, which comes out to be 14 millimeters of mercury. Okay, so the measured IOP will be less on Goldmann applanation tonometer after you do a LASIK. So, hello dear students, welcome to Insta Solution question number 10. Retinal cysts are seen in. So, classically, retinal cysts are seen in a chronic rhegmatogenous retinal detachment. So, this is the answer. So, friends, if you know the fact, you can answer this very easily. But if you don't know, it will be a tough question for you. So, let us quickly discuss how can you differentiate a case of a fresh RRD from a case of an old retinal detachment. Now, friends, when you have a fresh rhegmatogenous retinal detachment, usually it appears to be a convex configuration. You will have a corrugated type of appearance. This may extend to even ora. The retina appears to be elevated and you have a mobile retina. Now, this can be easily seen with some pictures of a fresh retinal detachment where you have a retinal tear. This is your characteristic horseshoe-shaped tear, and this is your detached area. So, retina appears to be elevated, isn't it? Apart from that, it may extend to ora. It has a corrugated appearance. Now, here again, this is your convex appearance. On ultrasound, you have an open funnel-shaped type of area which is attached to your optic nerve head. Now, this is very different from a case of old retinal detachment where the retina undergoes atrophy. It becomes thin. Corrugation is all lost. It appears to be smooth. It never extends to ora. The retina loses its mobility. It becomes fixed because of the PDR changes. Now, there are two very important findings which we see depending upon the duration of the detachment. So, when the detachment is 3 months old, you will see watermark lines. You call them some areas of pigmentation. So, try to see here. This is your watermark line, which is the area of pigmentation with the attached and detached retina. So, at the area where you have attached and detached retina, you will see some pigmentation. This is called as watermark. This typically tells you that Adie is approximately 3 months old. Apart from that, you may also see a cyst in the retina. So, this is classically a cyst in the retina, very well seen on ultrasound also. This tells you that the duration of retinal detachment has been over a year. Okay, so this is your old and your fresh retinal detachment, a very important